evening, respected Dr. Uma Ali ma'am, President Maharashtra IP, Dr. Ramgopal Chezara sir, Dr. Pawan Devre, today's moderator, and all the delegates and PG students who have joined from Zoom link and also YouTube link. So, as you all know, Maharashtra IP this year, under the presidency of Dr. Ramgopal Chezara, we have came out with various academic sessions, mainly tips in office practice, that is top, then protocols in pediatric practice. Apart from that, we have continued with journal journey with Raigad IIP and path, that is pediatrician section for teenagers healthcare. This is for adolescents, and we have combined this with Nasik IIP and AH also. So this learning with legends is another great interesting session we have come out this year, and this involves various legends who have taught us the pediatrics, various subspecialties across the years. So they are teacher of teachers. And now I request Dr. Ramgopal Chedara sir, President Maharashtra IP, to have his view on this session. Sir, please. Sir, you are muted. Please unmute.
Yeah, thank you, Amol. And good evening, everyone, and welcome you all. This is the series of learning from the legend. Now, this is the 4th episode. When we were planning for the session, when the topic came for the discussion was nephrology, and we could not find the most suitable legend is Uma Ali madam. Nothing better than her. And today she would be talking on the topic of common mistakes to be avoided by the clinician. A tale of decades of pediatric nephrology experience. So welcome, ma'am. And thank you for accepting our invitation on a short notice. Once again, I thank madam, and over to you, Amol.
Thank you. Thank you, Dr. Ramgopal sir, for your encouraging words. Dear friends, this session will be about pediatric nephrology, and ma'am will guide us through various cases. And to moderate this session, we have tried various people, but we could not find nothing better than ma'am's student and young budding pediatric nephrologist, Dr. Pawan Shivaji Devre. He's consultant pediatric nephrologist in Nasik. He has his kids kidney clinic. He's assistant professor at Dr. Vasantrao Pawar Medical College, Nasik. He has done MD Pediatric from the Sion Medical College. Then also he has done fellowship in pediatric nephrology at Wadia Children's Hospital under ma'am's guidance. Then he has done fellowship in transplant nephrology at Global Hospital, Mumbai. He has post-fellowship experience of 7 years. He's practicing in Nasik since last 3 to 4 years. He has co-authorized various journals, also research. He's in research also. He got first prize for oral paper presentation at ISHD conference in 2015 and also IPNA World Congress in 2016. He is faculty for pediatrics and nephrology meetings at state and at national level also. So I hand over the baton to Dr. Pawan Devre to take us in further session. Over to you, Pawan.
Yeah. Thank you, Amol sir, and thank you, Chezara sir, for giving me this opportunity to moderate the session. I extend my welcome to all the delegates who have joined from all the districts across Maharashtra. And to start this topic, we all know that avoiding mistakes is of utmost importance, and this is particularly true in the setting of pediatric nephrology cases, because as you all know that most of the kidney disorders, they start as a silent problem. They show very subtle signs, very simple signs, and which can get easily missed to begin with. And to point out these subtle signs, we have a very legendary teacher who can guide us, who can make us wise through her own wisdom, through the years of experience which madam has accumulated, and we couldn't have asked for a better speaker for today's session. Can we share madam's CV?
Pallavi ma'am, please share this.
My laptop is...
Yes.
A very proud moment for me today, because I have to introduce my own mentor and my guide who has taught me all the ABC of pediatric nephrology. I am who I am because it is because of Uma Ali madam, and it is my utmost honor for me to introduce Dr. Uma Ali madam. Uma means the morning twilight. In Sanskrit, Uma means tranquility, splendor, and fame. The name of in Hindi, Uma means Ananta Jnana Asimit Antariksh Pratishta Prashanti, and name of Hindu goddess commonly known as Parvati. Yeah, next slide, please. So, madam is a senior consultant in pediatric nephrology. She's the head of division at SRCC Children's Hospital, Mumbai. She's consultant pediatric nephrologist at Leelavati Hospital at Jupiter Hospital, Thane. And she's a university recognized, currently she's university recognized DNB pediatric teacher. And she's the director of IIP ISCCM fellowship training course in pediatric critical care for almost 2 years. And she was also a director of MUHS fellowship training course from 2015 onwards at Wadia Hospital. The next slide. Madam has started the fellowship program at BJ Wadia Hospital. It was a very arduous journey which madam has faced, and I have seen that journey very closely. Just a minute. So, madam started the fellowship program at Wadia Hospital, which initially was an institutional fellowship program. And because of her dedication, she could bring the International Pediatric Nephrology Association Fellowship at Wadia Hospital since 2010. And I myself is the same. I got the fellowship of IPNA at Wadia Hospital under madam's mentorship in the year 2014. Thereafter, Wadia Hospital became a recognized center of fellowship program, which was recognized by Maharashtra University of Health Sciences. And in the past, she has also been the medical director of BJ Wadia Hospital from 2005 to 2010. Next slide, please. So she has received the Lifetime Achievement Award in Pediatric Critical Care at NCPCC in 2017. And she has given several oration and keynote address in NAPCON 2020, in Maha IP 2020, and Maha Pedicriticon at Thane in 2018, and a very prestigious oration award in pediatric nephrology, which is the B.R. Nammalwar Oration Award, which she received in Chennai in 2018. And she gave that keynote address on challenges in pediatric nephrology for the pediatrician. Very recently, she is also given the oration of Dr. Armeda Fernandez oration at annual conference of Dr. Athawale Research Foundation in 2015 at Panvel. Next slide. So madam is a very astute clinician as well as academician, and she has written several chapters in textbook in pediatric nephrology in the and also she has written chapters in IIP textbook of pediatric cardiology, IIP textbook of infectious diseases. She has more than 60 publications in national and international journal, and she has been the panel in the expert committee on pediatric CRRT, which is a multicentric trial which is going on. And next slide. She has been in the consensus. She has been in the expert committee member in the consensus statement on nephrotic syndrome in hematuria, and also recently the guidelines which were released for steroid sensitive nephrotic syndrome and steroid resistant nephrotic syndrome, which were released in 2020. Next slide. And we all know, and I personally know, that madam is a very important founder of Kidney Foundation for Children, which was started in 2013. It is a non-profit foundation, and the motto of this Kidney Foundation for Children is towards facilitating the right care at the right time in the right manner for all children in kidney diseases. So under this Kidney Foundation, madam has done a outreach program for all pediatrician, and she has visited in more than 20 districts all across the Maharashtra, and also in few districts in the neighboring states. And the reason for what she was doing, why she was doing this, is to train the pediatrician to identify acute kidney injury, to identify chronic kidney disease early in the course, and to teach all the pediatricians that they should learn peritoneal dialysis, because it is a basic necessity because all the pediatricians from the interior should know this, because whenever the patient is in acute renal shutdown and there is no time for this child to be referred to any higher center, so peritoneal dialysis, if a pediatrician knows, a life can be saved. And this was the motto why madam started the program PD for pediatricians. That is, PD stands for peritoneal dialysis, which is to be learned by the pediatrician. And I myself has been part of 2-3 such a course of PD for pediatrician, and it was a very wonderful experience to work with madam at in this interior. And next slide, please. Yeah, so this is what I was talking about, the outreach program which was conducted in 33 districts. And madam also was the pioneer of this study to screen all the adolescent school-going children for hypertension, and an astounding 26,444 adolescent children from 10 schools were screened, and the data is published recently. And the data, to for everyone's surprise, that many children were diagnosed to have primary hypertension. And this is what madam's outlook is towards the society. Next slide. So since I have myself is I am a student of madam, and I know plenty of things which madam could teach to all of you. And as I've told you that many things in pediatric nephrology are very pediatric nephrology cases, they should show very subtle signs, very simple signs, and which can be easily missed. So madam will teach us today that what common mistakes are to be avoided, especially in pediatric nephrology cases. Yes. Over to you, madam.
Have to share screen. Yeah. Can you see the screen?
Yes, ma'am. Yes, ma'am.
Yes, madam.
It's okay. Yeah. So Dr. Ram Gopal,
Yes,
Dr.
ma'am.
Amol, Dr. Bhavesh, and everybody in the team, Thank you so much for inviting me. When Bhavesh first told me this is what he wanted me to speak about, I said, I'll have to think a lot because these are cases we see over time. It's not that we have it documented. So what I've done is I've put together few cases which I actually have seen, and from which, there are lessons to be learned. They're quite common mistakes that are made and common things which are missed. And as Pawan rightly said, kidney is a silent organ. If you have a neurological problem, you'll have something, seizures, altered sensorium. If you have a respiratory, you'll cough, have breathlessness. If you have cardiac, you're going to have palpitations, arrhythmias, or on auscultation. But unfortunately, the puffiness of face, edema, oliguria, hematuria, which we take as hallmarks of kidney diseases, are seen in only 20% of the patients. 80% of the patients are more or less silent, have symptoms and signs refer to other organs and symptoms, and hence may not be recognized as nephrology problems till quite late in the course of the disease. Hence, if we want early diagnosis and early treatment, we would need to look at this a little more carefully and not miss out these clues which we get in our way. So I put it into a few groups. And I think all of us who read Gray's Anatomy, I don't know if it's still there on the first page, this quotation used to be there that what the mind does not know, the eye does not see. So we need to know what we are going to be looking for. So that is important. And one of the important things today is your antenatally detected renal anomalies. And almost all pediatricians have to face that when they're called for deliveries or they see the baby afterwards. So this is the first case I'm presenting. This mother had antenatal ultrasound at 22 weeks of gestation. Her ultrasound showed bilateral hydronephrosis. The left kidney AP diameter was 8 millimeters, right kidney 7 millimeters. The bladder was distended and not emptying. This was mentioned in the ultrasound. The ultrasound was repeated at 34 weeks of gestation, and there was a little increase in the AP diameter to 9 and 10 on the two sides. The child was born full term, 2.9 kg, was a boy. He was voiding well. There's no problem in voiding. So he was reassured, not just by the obstetrician, but the pediatrician who had attended the delivery, that there is nothing wrong. Many children have this and they will outgrow it. The parents were anxious, first-time parents, so they said, should we do one more ultrasound after birth? They said, no need. So their parents were reassured, they forgot about it. Now, at 8 months of age, this child had high fever, and it turned out to be a severe UTI which needed hospitalization, IV antibiotic. At this point, ultrasound was repeated, and the right kidney showed a pelvic ileal system dilatation of 12 millimeters, and the left kidney 11 millimeters. And it turned out to be on MCU a PU valves. And he underwent, after correction of the infection, he underwent fulguration of the valves. Currently, he's almost 8 years old. He has normal serum creatinine. He's not had any UTI after that. But his left kidney is small and scarred with 23% function. And right kidney shows peripheral cortical defects on DMSA scan, which suggests there is some scarring on the right side also. So this child, in spite of having, I would not say, I call it even a clue. I would say this is the direct murder which is visible on your face. You don't have to look for clues. You have a male child, you have bilateral hydronephrosis. It's obligatory to rule out PU valves. So this amount to not miss clues, this would amount to negligence in today. So I would say that any male child who has bilateral pelvic ileal dilatation, you have to do, of course, an ultrasound postnatally if you've detected antenatal hydronephrosis. It has to be confirmed by postnatal ultrasound because the two may differ. We also, if it's a male child, it's always better to do an MCU to rule out PU valves. Normal voiding does not exclude PU valves. because for a number of times, parents don't know how the child voids. Okay? First 2 days when they are in the nursing home, child's first 2 days voiding is not very high. Nobody may have seen how much he's voided or how he voids. They would have only known he's passed urine. That's what we are looking at. Has he passed stools? Has he passed urine? And then nowadays, most children are in diapers. So parents have never seen the child voiding. And first time parents do not know this voiding is normal for this child at this age or abnormal. So today, the voiding history for PU valves is misleading. If you have a clear difficulty in voiding, it's conclusive. But if you do not have a positive history, it does not mean that there's no PU valve. So we should not get fooled by the history of good voiding. So the AP diameters which are of significance, which will require prenatal follow-up, repeat ultrasound, is if your AP diameter is 4 millimeters in the first trimester, 7 millimeters in the second trimester, or more than 10 millimeters in third trimester. So 4, 7, and 10. If you find it easier to remember as 3, 6, and 9, there's no harm. So what are the additional things we are looking at when we see this hydronephrosis, unilateral or bilateral? That is the bladder empty. Now, the bladder emptying in fetal life takes at least, a observation period of 30 minutes to 40 minutes. So it needs a proper anomaly scan. So if it's just being roughly seen by the obstetrician, we cannot be sure. If an ultrasonologist who's dedicated to fetal scans is doing, then they will note that during that time they took to do the fetal scan, did the bladder get emptied or no? A bladder which does not empty in this observation period of 40 minutes, you have to have serious doubt that it may be an obstructed bladder. The other thing we look at is oligohydramnios. This may not be there in your first or second ultrasound, but it may come progressively because in the background of hydronephrosis, oligohydramnios may indicate that this kidney associated with this hydronephrosis may be not a good kidney, it may be a dysplastic kidney. Other subtle signs which are there, which may be reported, should be reported by the sonologist, is the appearance of the kidney. So if they report the kidney as a hyperechoic kidney or kidney with some cysts, then that is not a good kidney. That kidney's function is a questionable function postnatally. It's not that it won't function at all, but these are kidneys which in the long term may lose function. So these are all the things we are looking at to get an idea of what we may be dealing with postnatally and also how severe that may be. So in terms of repeat ultrasound, whenever you see antenatal hydronephrosis, even if it does not look very significant, one should repeat an ultrasound postnatally. Usually that is after day 3 of life, unless you strongly suspect PU valves, then you do it earlier. Another important thing which most of us do not know or forget is supposing your day 3 ultrasound is normal. The recommendation is to do one more at 2 months before you say nil active nephrology and not to worry. So you need 2 postnatal ultrasound, one in the neonatal period, 2 months before you can safely say that this is probably not a worrying problem. Now, not everything we see antenatally has got pelvic ileal dilatation. And most guidelines talks are always about pelvic ileal dilatation. But you also have other things, something which are subtle. Like this child, again, was antenatally detected to have just hyperechoic kidneys. Means kidneys are looking brighter than they should normally. They were normal in size. There was no pelvic ileal dilatation. So literally everything normal except that the kidney looked brighter. So this child again was reassured by obstetrician, pediatrician that there's nothing wrong, there's no dilatation, this child will be okay. So nothing more was done. At 11 months of age, this child had seizures. He was admitted in a hospital and the blood pressure they found was 180 by 120 at 11 months of age. And his hemoglobin was 6.5 and his creatinine had already gone up to 8 milligrams per dl. So he was in advanced renal failure, and they were started him on dialysis. And subsequently, in Vadia, we had put him on CAPD. And then after 3-4 years of CAPD, he got a cadaveric donor transplantation. Today is more than 4-5 years post-transplant and doing well. So the thing is that even though this looked like nothing much, this turned out to be worse than the PU valves, because the PU valves child at 8 years has normal renal function still. We are worried what will happen when he's 18 years. But this child went into renal failure at 11 months, but he had hyperechoic kidneys, which was a clue that there's something more. Okay? So this may not be a developmental anomaly. Sometimes it is. Dysplastic kidneys look bright. These may also be indicative of some hereditary disorders. And this child turned out to be a hereditary disorder, which is an infantile nephronophthisis, not a very common entity, but which goes into renal failure very early. So absence of pelvic ileal dilatation does not rule out serious renal disease. So if you see any abnormality, they would need follow-up. Okay. So when we say CACUT, we are talking a collective term for all congenital anomalies of the kidney and urinary tract. So the acronym is CACUT. So to sum up, all patients with renal anomalies on antenatal ultrasound need to be evaluated and monitored. This includes children who have undergone surgical correction for renal anomalies, because they still may have renal functional abnormalities which may show up later. This also includes children who do not have any pelvic ileal dilatation but have abnormal looking kidneys. Most patients will maintain normal renal function, but late deterioration does occur, and renal failure due to CACUT occurs across all ages. Not all of them will go into renal failure in the first year of life. It may be in childhood, it may be in adolescence or as young adults. So they should get the benefit of a pediatric nephrology consultation and periodic follow-up. So those with pelvic ileal dilatation and those without, we need to separate out. In those with pelvic ileal dilatation, we're basically evaluating to see, do they need surgical intervention? That is your main decision which you have to take. And sometimes it may change. It may not need in the beginning, might need later. And so children who have antenatally diagnosed dilatation have to be followed up, evaluated for need of surgical interventions. And obviously the children at greatest risk are those with lower urinary tract obstruction. One is that surgical intervention gives you anatomic correction. Does not automatically mean that there's a functional improvement. So all of them will need functional evaluation after surgery also, periodically, to ensure that this kidney is remaining with good function through life. Okay. Now, the second group of patients I've put as from the orthopedic diary. It's about a girl who couldn't walk and a boy who couldn't climb stairs. Okay. Now, this was a 6-year-old girl with inability to walk. The parents said that she barely crawled, but she never stood up and she never walked, even at 2 years, 3 years. That was the history we saw at 6 years. She had severe bony pains, so she would not like being touched also, and recurrent fractures. She had received multiple high-dose vitamin D, almost like 18 times she was given 6 lakhs units, which is what we used to give in those days. And she was referred to orthopedic surgeon for corrective surgery. She also underwent 3 surgeries, all 3 were osteostomies. Each time after 6 months, the deformities would recur. At this point of time, she was referred to pediatric nephrology, mainly to rule out any metabolic problems that is affecting the bones. Okay. And this is what her bones look like. They were absolutely rarefied. They were bent, pathological fractures. And when we did a basic renal investigation, BUN, creatinine 0.8, may be okay, may not. Electrolyte showed hypokalemia, hyperchloremia, bicarb was low, So she had a hyperchloremic metabolic acidosis. She had little low calcium, low phosphorus, very high alkaline phosphatase. Obviously, she has a bone disease over there. So obviously, the suspicion when you have metabolic acidosis like this with near normal or normal creatinine is we are dealing with the renal tubular acidosis. So question comes, should we treat at this point directly or should we investigate more? It's always important to distinguish at least between distal RTA and proximal RTA for two important reasons. One, distal RTA has a problem that they can develop nephrocalcinosis, which those calcium deposits in the kidney can in future harm the kidney. Proximal RTA, on the other hand, are like Fanconi syndrome. They don't just have acidosis and low bicarb. They lose many things. They lose phosphorus, they lose potassium, they lose various other glucoseuria, amino aciduria. So it's multiple solute losses that occur. And many of them are secondary to other metabolic disorders. The most well-known is cystinosis and may require specific treatment for the metabolic disorders. So this child, when investigated, had a proximal tubular defect, a Fanconi syndrome, she had metabolic acidosis, hypophosphatemia, glycosuria, and amino aciduria, which is a classical picture of Fanconi's. We couldn't find any secondary causes. So we had to address all these issues, treatment which we needed to give. So sodamine, potassium supplements, phosphate supplements, calcitriol. And there was a gradual improvement. And subsequently, she underwent corrective surgery. And then almost, I think this was at the age of 12 or something, where she actually took her first step and started walking. What was missed in the history is polyuria polydipsia. Now, this is something we need to ask anybody who comes with a bony deformity, because most of them are secondary to tubular defects if it's due to a renal problem. So they'll have a concentrating defect, and that will be manifest as increased urine output. Now, sometimes parents, this child never walked, so parents knew many things. But if the child was already walking, parents may not know how much urine the child passes in the daytime. But they'll never forget if the child is wetting the bed or getting up to pass urine many times. So these children have nocturia. So the polyuria extends into the night. And so either they'll also have nocturnal enuresis or they'll get up multiple times at night to pass urine and also drink water. So the drinking water will be not just in summer, but in winter time also. So this is a very important history to detect renal disease. That what is the urine output? We are tuned to thinking of oliguria. So if the parents say they pass good urine, we think there's no renal problem, but good urine may not be good for the patient, depending on the how good it is and what is the underlying issue. This child, Caden, is an 8-year-old. When he came to me first, he was under investigation for last 1 year or so. For difficulty in running, he could not play with the other children because he couldn't run well. And he couldn't climb stairs. This was his complaint. And according to them, earlier he could, and now since 1-2 years. So initially he had some knock knees, so he went to the orthopedic, but they didn't detect anything that would interfere with his climbing and running. It was nothing that bad. So he was referred to neurologist. Neurologist did a thorough examination, including EMG, nerve conduction, found everything normal, but he had a little anemia, hemoglobin 7. So he was referred to hematologist. Hematologist did every workup for hemolytic anemia, including rare conditions which I do not know because I'm not so deep in hematology. And then, but at some point, the hematologist did BUN creatinine and found that the creatinine was 3.5 milligrams. And so he came to nephrology. And then besides the creatinine, he had metabolic acidosis, high phosphorus, low calcium, secondary hyperparathyroidism with very high PTH. The interesting thing is that this metabolic thing to improve, not totally normalize, may have taken about a month with all the supplements. At 1 month follow-up, he came to the clinic and he was jumping. So I asked the mother, why is he jumping in the clinic? She says, no, he wants to show you that now he can even jump. He couldn't run before, now he can jump also. He just wants to show you that. So these are things which get missed. Now, this child also had polyuria, polydipsia, which nobody asked the history. And the parents didn't volunteer because they didn't think it was anything abnormal also. But a combination of hematological problems, bony problems, little neurological, apparent neurological issues should raise a concern that maybe we are dealing with something else which is affecting all these systems. The neurology part, people are less aware, but children with chronic renal failure who have high secondary hyperparathyroidism often have proximal muscle weakness. So you may even be able to elicit a Gowers sign and be misled. So it's the association with all the other things that brings the doubt that this is not a plain and simple, I mean, those are not simple cases, but not a one system case. So the commonest metabolic causes of bony deformities are renal disease. Not all bony deformities are renal disease, but this forms an important segment. And one should always basically rule out at least the common ones before one proceeds to an orthopedic referral. And to just name a few common ones which we are likely to see more commonly, one is a chronic kidney disease like the last patient I showed you. Second is renal tubular acidosis like the girl I showed you. And the remaining are rarer ones. They are not common, but occasionally you may see things like hypophosphatemic rickets, dense disease, or hypocalcemic vitamin D dependent rickets, which may be there. So I would say refer to nephrology before you refer to orthopedics. Let them rule out a renal problem and then refer to orthopedics. The third group are the clues we miss. There are obvious clues, but somehow we don't think they are important or whatever. We are not paying attention to them. This is a very common case which all of us see at some point or the other, is an acute post-streptococcal or post-infectious glomerulonephritis. A 10-year-old boy with puffiness, pinkish urine, reduced output, blood pressure 119/70, mild albumin plus, RBCs 80 to 100, ASO high, C3 low. So it's a clear-cut post-infectious glomerulonephritis that we are seeing. But what happened is next day the child had seizures with a blood pressure of 150 to 90. So what went wrong? We had a blood pressure the previous day of 119/70. Problem is we did not check whether this blood pressure was appropriate for his age. Now we have screening tables which are available, which you can have at your clinic. So it knows, okay, if it's above this value, please recheck and see what it is. So for a 10-year-old, I'm sorry, that's shown higher. The screening values are about 108 systolic blood pressure and 72 diastolic pressure, whereas this child had 119. So he's definitely above a value which you need to recheck. So what we need to do is do a second BP to recheck if this is true. And then we have these tables. The writing is too small to be displayed on this, where based on the height, you have separate for boys and girls. You can see what is the BP and then see which centile it comes to. I've enlarged this for 10 years. So you can see the height of the child. This child was less than 130 centimeters. So it was less than 5th centile. But we chose the 5th centile to see. His 95th centile is 112. And we had 119. So it was already 7 millimeters above the 95th centile. And we never thought it abnormal because we merely eyeballed the BP. It's less than 120/70, big boy, leave it alone. And so the next day it increased because AG and BP can increase after the initial onset. So it's always important that we should not miss hypertension. Okay? The reason we miss, 3 are common, the 4th is less common, that we have not measured BP at all. So we missed it. Second, we measured the BP, but it's an inappropriate cuff or inappropriate method. not the right one. So we have errors. It's either more, less, etc. And most important is the third one, that we are not checking the values from the BP table based on age, gender, and height. We are just eyeballing with some mental numbers we've stored that this is okay and this is not okay. And in pediatric age, since the BP varies with age and gender and height, that we cannot remember so many numbers, so we should always check from the tables. Sometimes the mistake may not be from our side, but when the BP affects the heart so badly that you have your ejection fraction very low, the systolic output is so low that your BP is not high anymore. So you may miss the high BP in a child who has cardiac failure because of hypertension. So that is a little less common situation which you would get. The first three are the common ones which mistake we make. We not only have missed clues, we have sometimes red herrings and misleading clues, that we are following a wrong track because it's there, but that may not be the true cause of the thing. So let me put this case. This is a 4-year-old child who was referred for incidentally detected asymptomatic hematuria. But on history, they gave that there was some gross hematuria at some point, 1 or 2 episodes, but which said, again, urine albumin was 1+, RBCs 100 to 150. Ultrasound was normal. Urine calcium creatinine was done, which was 0.3. Now, when we do calcium creatinine ratio, we take a cutoff of 0.2, and anything above that we say is indicative of hypercalciuria. And we know that hypercalciuria can cause hematuria because it's a precursor to stone formation. So it may be like crystals which are irritating the tubules, and you have some bleeding. So this child had been treated for hypercalciuria, but the hematuria didn't go away. It kept, every time there was a test somebody bothered to do, there was RBCs in that urine. So this was pursued, a repeat ultrasound was normal, then a cystoscopy was done, which was again normal, a CT scan was done, which was again normal. So no cause was found for this hematuria. So 2 years later, this child again had one gross hematuria. This time urine albumin was 2+, RBCs were 200. BUN 16, creatinine 0.8. But this time, the 24 hours urine protein was quantitative, and it was in the nephrotic range. It was 3.8 grams in 24 hours. So biochemistry was done, albumin was low, 2.8, cholesterol was little high. C3 was done, which was borderline low, and a biopsy was done, which showed a very rare glomerular disease, a membranoproliferative glomerulonephritis, which we call dense deposit disease because it has very dense deposits on electron microscopy. So this is a very serious disease which has no effective therapy and may go into renal failure. So what was misleading here was the presence of hypercalciuria. Now, hypercalciuria, at least in our region in Maharashtra, is very common. Okay? You test for it and very often you find it. So we take as urine calcium creatinine greater than 0.2 as significant in children, and in infants greater than 0.6. But however, for calcium, we should confirm it by 24 hours urinary calcium to document that there is true hypercalciuria. So since hypercalciuria is common, it may not necessarily always be the cause of hematuria. Although it can cause hematuria, it may not always be the only responsible agent. It's just like how when you get your MANTU test positive, but not necessarily all the symptom signs you have is of tubercle. The patient may have come for some other problem and you've also detected this. So very important is we must always check for proteinuria when there's hematuria, because proteinuria is a hallmark of glomerular disease. And glomerular diseases with hematuria and proteinuria definitely need renal biopsy and additional investigation. So the most important test for hematuria, I would say, is proteinuria. Do not forget that. Quantitate the protein. Now, if hypercalciuria is persistent, there's a tendency to consider it as idiopathic hypercalciuria and treat it with thiazides. Now, we need to remember that not all hypercalciurias are idiopathic in nature. Idiopathic hypercalciuria is a diagnosis of exclusion. Okay. So you may have you have to first rule out hypercalcemia causing hypercalciuria, because these are dangerous diseases. So common is vitamin D excess or hyperparathyroidism if you also have high serum calcium. But majority of the time we find that the serum calcium is normal or little low, not high, but has hypercalciuria. Common here are distal RTA and Bartter syndrome, which need exclusion by history and simple test. But there are also many rarer ones, the hypomagnesemic, hypophosphatemic hypercalciurias, dense disease, calcium sensing receptor mutations, etc. So this list, as we grow in genetics, is increasing. So even we not exclude everything, we have to exclude common diseases which we may miss and get sidetracked by the hypercalciuria. So I have a rule of 5 for hematuria, which I think will cover most hematurias. One is, what are your 5 common causes? One is glomerulonephritis. Different kinds come under that umbrella. Stones, urinary tract infection, not very common, but younger children, yes. Hypercalciuria and drugs. These are your 4-5 common causes. Drugs, especially the NSAIDs like ibuprofen, most notorious for causing hematuria. So you have to always ask for the drugs. There are 5 indications for renal biopsy in a hematuria case. One is any hematuria with proteinuria, which is persisting. Any one you have diagnosed as AGN where the gross hematuria lasts more than 3 weeks. Any AGN which has an increasing serum creatinine. Some of them will have little raised creatinine at admission, but within a couple of days, you are seeing a downward trend. If your asymptomatic hematuria, which you've just incidentally discovered, persists for more than 12 months, or if you have recurrent gross hematuria occurring and you've not found any other cause, and it's continuing beyond 6 months. So these are some of the important indications where in the background of hematuria, you should consider you need a renal biopsy. 5 tests that are no use for hematuria, don't do it. IVP, MCU, DTPA scan or DMSA scan, CT scan, cystoscopy. Absolutely no role in hematuria. They don't give us any information. So unless you have a specific reason, like you ultrasound has shown a tumor, you're considering a tumor as the cause of hematuria, then you may need additional imaging. But where your ultrasound has not shown any such things, going for advanced imaging is of no use. So that's about hematuria. We also have some more misleading clues, or maybe we are not so aware and so we get misled by those clues. And so this is largely in the segment of urinary tract infections, which is one of the commonest things we see. Now, this is an 18-month-old child who presented with recurrent UTI. That's what the parents said. He had high fever to begin with, which was about a month or month and a half earlier. He had no other symptoms. Urine routine was normal, but urine culture showed E. coli 10 raised to 5 per ml. So he was treated as UTI with antibiotics. He became afebrile within 24 hours. An ultrasound was done, which was normal. But he was advised to do a repeat urine culture after 1 week or 2 weeks to ensure everything remained normal. So child was clinically well, had no fever, but he repeated urine culture, and the urine culture again showed E. coli 10 raised to 5. This time it was ESB and E. coli. He was treated with piperacillin tazobactam. This time an MCU was done and there was no VUR. Now, again, because he had these 2 back-to-back infections of increasing resistant bacteria, he was advised to do urine culture again after 15 days of stopping treatment. Urine culture done after 15 days showed now E. coli, which was carbapenem resistant. He was admitted and treated with colistin. And he was further advised to repeat MCU as VUR may have been missed. Now, that is what alarmed the parents, a second MCU. So they came for a second opinion. Now, when we took the history, symptoms was there only once, fever. There was no other symptoms in any of the time. If you asked in detail how they collected for culture, it was totally erroneous. Some of the cultures were so badly corrected that you would have put it down as a contaminant. I've known patients when I've asked how they collected for culture, they said we collected in the culture bottle. I said, did you clean the genitals? Did you try to take the midstream, cap it, put it in ice, etc.? They said, no, we clean, but we took out the diaper, kept him on a Macintosh, and when he passed urine, collect the urine from Macintosh. So the E. coli is not coming from the urinary tract, it's coming from the rubber sheet which they put underneath. So the infection is in the sheet and not in the patient. So how have they collected is very important before you take that as a significant finding. So very important, we have to differentiate UTI from asymptomatic bacteria. So UTI means there have to be three components: symptoms which are compatible with UTI, urine showing pus cells, and a properly collected culture sample showing a single organism 10 raised to 5 per ml, then most probably you have a UTI. When we say asymptomatic bacteriuria, we are talking of somebody who has no symptoms. But for some reason, we've done a culture and that has grown something. This asymptomatic bacteria, one, if there's no symptoms, don't do urine culture. Second, if you have somebody is done and you're seeing, do not treat asymptomatic bacteriuria. Asymptomatic bacteriuria should only be treated in pregnant women and in neutropenic patients. Others do not need treatment. It, in fact, gives rise to more resistant colonizing bacteria. This is another child, 12-year-old girl, 1 month of fever, urine albumin 2 plus, RBC is 20 to 25, WBC is 80 to 100. Treated with antibiotics but didn't improve. The antibiotics were changed, but persistence of fever, repeat urine showed albumin 3 plus, RBC is 40 to 50, WBC is 50 to 60. And this whole process was almost 3 weeks by this time. Creatinine was done, which showed 1.85 milligrams per dl. So this child actually was referred as a resistant UTI, which is not responding to various antibiotics and is having now rising creatinine. Now, the creatinine by the time we saw was 2.2 milligrams. Because of the proteinuria, we did a 24 hours urine protein, which was 2,675 milligrams. ASLO was negative, C3 was negative, ANA was negative. But we did anti-GBM antibody and ANCA, both of which were positive. This is anti-glomerular basement membrane. Did a biopsy, it was a crescentic glomerulonephritis with linear deposits of IgG and C3. So this was a good Pasteur syndrome. And this child needed IV methylprednisolone, cyclophosphamide, and plasma exchange for the treatment. So what was the mistake over here which happened is all WBCs in the urine do not mean urinary tract infection. So pyuria is not equivalent to UTI. Any inflammation in the kidney will give us pyuria. So this was a glomerulonephritis which had inflamed the kidney. So we are getting pyuria. So what we missed focusing on is there was also a lot of proteinuria. Okay, so we should always quantitate and see, because a UTI may give you bad pyelonephritis, may give you some proteinuria, but it will never be in the nephrotic range. So to say about UTI, you have to have three things. One is your symptoms suggestive of UTI, pyuria, and culture growing a single organism with colony count of 10 raised to 5. Now you have three other situations. On the left-hand side, you have fever, you have pyuria, but your culture is negative. Now, this is unlikely to be a UTI unless somebody has given antibiotics and you've given the culture after that. The pyuria may be due to some other cause like inflammation, stones, hypercalciuria. And the second group on the right-hand side is fever. There's no pyuria but culture positive. Here you have to be very suspicious. Are you dealing with an asymptomatic bacteriuria? Was the collection of culture for culture proper? Whether you should believe this culture or not believe it. The fever may be due to something else. So you have to be very careful when you have no fever. And the fourth one is no fever, no pyuria, only culture positive. This is asymptomatic bacteriuria and should not be treated. So you have many misleading clues because we tend to equate all pyurias with UTI and we equate all culture positives as genuine culture positive and treat it as infection. This is also interesting. Also a UTI, 6-year-old boy with recurrent febrile UTI. MCU showed bilateral grade 4 VUR. Failure of medical therapy, UTI despite that, underwent bilateral ureteric reimplantation. No further UTI is doing well, followed up well, creatinine 0.6, subsequently lost to follow-up because he was overall well. There was nothing on the repeat at 1 year follow-up. Creatinine was 0.8 milligrams. Repeat MCU was done by the surgeon, no VUR. And urine routine showed trace proteins, no WBCs, no RBCs. He came back to the surgeon at the age of 15 years. He was well grown and his blood pressure was 150/90 and a creatinine had been done and it was 3.5 milligrams per DL. So he went to the surgeon to say, why has this happened when he had such a successful surgery and no further UTIs? So what went wrong here? One is we did not quantify the proteinuria. We saw the trace proteinuria at 1 year follow-up and took it as okay. Now, proteinuria is hallmark of renal injury, and a dilute urine may show trace or absent proteins even when your 24 hours urine protein may be. So urine protein should always be quantitative. Normal urine protein to creatinine should be less than 0.2. And if you have persistent proteinuria, especially if it's increasing proteinuria, it's a risk factor for progressive kidney damage. The other mistake that we made was GFR was not estimated. Now, GFR estimation is very simple. It's a mathematical calculation. Height in centimeters upon creatinine in milligram per DL, and you multiply by a constant value of 0.55. This is a constant value used depending on the methodology you're using for creatinine. Most centers still use the Jaffe's method, so 0.55 is okay. So if we had calculated the GFR, we would have known that it was 72 ml at the time of discharge from hospital. And 6 months later, it dropped to 57 ml. So we would have been alerted that there's something here that is not going all right. And so we need to, all renal patients, including those who've undergone surgery, especially if they've had scarring, PU valves, etc., proteinuria and creatinine has to be monitored annually or periodically. If possible, we should measure creatinine by an enzymatic or kinetic method, which reflects true creatinine better than Jaffe's method. So a creatinine of 1 milligram is not normal in the pediatric age group. Labs give you adult values as normal and we get misled. Usual range in pediatric age group should be less than 0.8. And why is this important? Because a GFR up to normal GFR is 120, the green portion 120 to 60. Although there is a decrease in renal function, it's gone below 90. Is an area where you can still treat the primary disease well and prevent progression of the disease. But in the yellow portion where the GFR is between 60 and 15, it's a wide range of CKD stage 3 and 4, there will be a lot of metabolic problems like anemia, bone disease, acidosis. which needs good correction to ensure good health as well as preserve or prevent rapid progression of kidney failure. And when the GFR falls below 15, you are in advanced kidney failure and the child has to be receiving renal replacement therapy. So by calculating it, you know in which color zone you are and what one needs to do. Lastly, to go somewhere, we take a different route. To go to Colaba, we first go to Andheri and go. So many renal diseases get diagnosed in a very roundabout way. This was a 15-year-old boy, came from the village, presented with URTI. Both his height and weight were below the 5th centile. The father had come basically because he felt the child is not growing well. Mild anemia, which was microcytic hypochromic. Treated for URTI, sent home with iron and folic acid supplements and nutritional advice. But the child was not growing so well, so consulted several pediatricians for poor growth, but he did not improve with all that. So he was referred to the endocrinologist for assessment of growth. And so the endocrinologist was a renally oriented endocrinologist. He did not do hormone studies. He first did renal function, and BUN was 70 and creatinine was 9. An ultrasound showed bilateral small shrunken kidneys. So when should we suspect that failure to thrive could be due to renal disease? Because we have so many causes of failure to thrive and nutritional problems are so rampant. It's when your failure to thrive is associated with recurrent dehydration episodes, vomiting off and on, presence of bony deformity or rickets. Generally, florid rickets with deformity we should not be seeing in a malnourished child because rickets is a disease of growing bones. So if bones are not growing, then why are you having rickets signs? So if you see both malnourished child along with bony deformities, there must be an underlying cause. And if there's also failure to thrive but very short child, these all, and this is the kind of child where you should ask about polyuria, nocturia, getting up at night to drink water. So last case, this was a very confusing story. This was a 7-year-old girl who had anemia, unresponsive to hematinics. Investigated extensively. No cause was found. They took second opinion from well-reputed hematologists and pediatricians in different parts of the country. A bone marrow biopsy was done, which showed myelofibrosis. Transfusion was needed once in 3 months, and they were advised the need for bone marrow transplantation. Now, this family went to a different city to attend a wedding, and there the child became acutely breathless, found to have pulmonary edema with a creatinine of 5, needed emergency dialysis. An ultrasound showed bilateral small shrunken kidneys and end-stage kidney disease, and the nephrologist advised kidney transplant. So they're very confused. Does he need kidney transplant, bone marrow transplant, both? Which one should be done first, etc. So they came for a second opinion to me. And very clearly, this anemia was due to CKD. Myelofibrosis occurs in CKD due to long-standing untreated secondary hyperparathyroidism. So it does not mean it's only a primary hemat problem. And actually, the pathologist who interpreted that myelofibrosis was very astute. He had put a note to reduce serum creatinine and PTH after he saw the myelofibrosis. But everybody ignored it because they thought the pathologist doesn't know anything clinical. And so, we go with like a horse with blinders that way. We don't see left, right, we see only in front. So nobody paid attention to that. So this child basically needed kidney transplantation, did not need bone marrow transplantation. The bone marrow has a good chance of recovery once the uremic milieu is totally gone, and the hemat recovery can be reviewed afterwards. So which anemia, since it's so common, we should consider investigating for renal? Is any anemia which is poorly responsive to iron and hematinics. You've given it for 3 months, you're sure the child has taken it well, but you're not getting the kind of response you were expecting in 3 months. Either no response or partial response. Unless you have overt signs of a hemat problem like a thalassemia or anything, just do a BUN creatinine before you go for advanced hemat studies. So I would sum up by saying check BUN creatinine before referring to hematologist for refractory anemia, before referring to orthopedic surgeon for deformities, before referring to endocrinologist for short stature or hypoparathyroidism, resistant rickets, and before you refer to neurologist for unexplained walking, climbing difficulties. And needs very simple tests. 5 tests can detect most renal diseases. A urine routine, don't ignore any findings. Hematuria, pyuria, proteinuria. Don't get fooled by trace proteins, 1+ proteins. Always quantitate proteins, do at least a urine protein creatinine ratio. It's more than 0.2. You find nothing else, at least keep the child on radar with a note that repeat is needed after a few months. Check a serum creatinine, ultrasound by good ultrasoundologist who's pediatric renal oriented, and sometimes may need interpretation by pediatric nephrologists. And lastly, a blood gases if you find everything else normal, but you have a suspicion of a renal problem. So they're simple tests, they're not expensive tests. And I would say 80 to 90% of renal diseases can be detected with just these 5 tests. So we need to follow the right clues. Sometimes we may have multiple footprints. We need to know the footprints of each renal class of renal disease, like glomerular will have puffiness, edema, oliguria, hematuria, proteinuria, glomerular disease. Tubular disease, poor growth, failure to thrive, maybe bony problems, maybe anemia, and polyuria, polydipsia, nocturia. Those are your clues that look at the kidney before you look at other things. So you have distinct footprints by which you can trace what you're looking at. And you need to follow the footprints to get a diagnosis or exclude a diagnosis. Thank you.
Yes. Thank you, Umali Madam, for an enlightening and enriching session. So we will start the discussion. So I have a few points which I will ask you, Madam. And there are few questions from the audience also. And we will take those questions. So about this cases of ecogenic kidneys which are reported in the fetus in antenatal scan. So, madam, if this antenatal mother comes to you with the report showing ecogenic kidneys, so what will be your advice to them? Because many times the antenatal mothers, they go to pediatrician and they ask that how this baby will be in future.
See, I think from the
Ma'am, can we stop the sharing?
Yeah, I'll do that. Yeah.
Yes.
I think I'll leave.
Yeah, you can answer from mobile only.
Video. Pawan, Pallavi ma'am has sent the recent questions to your WhatsApp also.
Okay.
I think madam has.
So we have to take all the questions.
Yeah. I have taken a note of all the questions from the messages.
She is also sending
from the chat from the chat box.
Yes.
I think madam has logged out from both the simultaneously.
We'll wait.
Yeah. Yeah.
Yes.
Yes, ma'am. Pallavi, unmute madam.
Sir?
Madam ला unmute करा ना, कारण मॅडम आता मोबाईल वरनं लॉग इन झालेत म्हणून.
See
Make her
from
co-host.
Yes, yes,
ma'am
sir.
has
Just
to
a
do.
minute.
Yes, yes.
Yes.
Yeah. Yeah, now I'm unmuted. So you can hear me?
Yes,
Yes,
ma'am.
ma'am.
Yeah, okay. So the
Yes.
hypercoic kidneys, one thing also to look at is oligohydramnios. To see that if you have hyperechoic kidneys and oligohydramnios, then this is a serious combination, and this kidney is likely to function very poorly even postnatally. In the absence of oligohydramnios also, we need to caution them that this kidney is not looking normal. These are likely to be have some functional problems, and we'll not be able to say whether those functional problems 100% will be there or when will it occur, but they will need a close follow-up for renal function. So I don't think beyond that we are in a position to counsel anything for such cases, unless there's been an index child whom you've diagnosed.
Okay. So many a times the parents will ask directly a question whether to continue or terminate this pregnancy.
See, I'm glad you asked this question. We are not God. Terminating any pregnancy is not our right. Neither advise on that directly unless it is incompatible with life. Okay. So renal diseases don't come under that category. They are no longer incompatible with life. There is options for it. And there's a lot of variation when they are born of how each child behaves. So always when counseling, we have to tell the parents what they're likely to face postnatal. Give the postnatal possible scenarios. Usually it's not one single scenario, the good, the better one and the worst one. And with whatever signs we have, we can tell them this looks a little more like a worse one or a better one. Whether to terminate or not terminate is the parent's decision. And I don't think we should be the person deciding that or guiding towards that at all.
Okay, madam. And ma'am, there is one more question from the audience that if the antenatal scan is showing only oligohydramnios, but the kidneys have been reported as normal. So is it necessary to do a postnatal USG to look at the kidneys?
See, if your antenatal is totally normal kidneys, then postnatal I would watch for urine output, everything. I would still keep that child under observation for a few months, keeping in mind the said oligohydramnios. But kidney is not the only cause of oligohydramnios. You have placental causes for oligohydramnios as well. So you may have normal kidneys and still mother may have had oligohydramnios. But one would need to kind of at least follow up for a little while to make sure everything is okay.
Okay. And another question which has come up is that a child which is whose USG is showing hydronephrosis, hydroureter bilateral, and MCU has come as normal. So should we repeat an MCU or should we take it as a normal MCU? And
See,
USG is showing thick bladder.
An MCU has to be properly done. MCU has to be done by somebody who's used to doing pediatric MCUs. And you should have all the plates. You should have the plain plate before you instill the dye, then with the full bladder, then when the child is actually voiding, and a slightly oblique view while voiding. And that plate should include the abdomen part. Very often you get only the bladder and not the above part. So only if you have all these pictures, including the post-void picture, can you opine on an MCU and say it is really normal. So that is one part. Be sure that this is an MCU worth opining on. Don't opine on an MCU which is badly done. Second, reflux. Yes, you can miss a reflux on MCU. One, if it's not properly done, maybe. But also, reflux may be intermittent. It may not be present all the while 24 hours. So you may genuinely miss a reflux on MCU. A small percentage do get missed. But I don't think if a well-done MCU has shown no reflux, I don't see any point in repeating that. Because you have other causes for hydroureter, like there could be maybe some obstruction at the junction of the bladder with the ureter, which is not common, but we do see vesico-ureteric junction obstruction. And sometimes you just have megaureters. Ureters are big. They are neither refluxing nor obstructed. So those entities do exist.
So one more question related to antenatal scan is if the antenatal scan is showing bilateral hydronephrosis, but the postnatal scan comes as normal, so what should be the further evaluation?
I think I mentioned this. There's a small number of patients where the postnatal scan is normal, but you repeat it a couple of months later, you find some abnormalities. So you have to always tell the parents it's looking normal, but we need to see one more scan when the child is around 2 months old. If 2 postnatal scans are totally normal by a well-done sonologist, I think then that thing has resolved spontaneously.
Okay. So now that we are on topic of good sonologists, many places especially in the interiors, the sonologist may not be in tuning with doing a good renal sonogram. So should we communicate with the sonologist, and what should we tell the sonologist to look for?
I think every time you have to communicate with the sonologist because see, in the sonology training, how much pediatric exposure they had and how much pediatric nephrology exposure they had will also depend on whether there were pediatric nephrology services available in the medical college or wherever they train. So it is very variable as we stand today. So the sonologist may be very good, but may not be pediatric tuned. Okay. So the communication is important, that what are you looking at and what are all the things you want them to report. So usually you specify that you want kidney sizes, you want to know PCS dilatation, parenchymal thickness, ureteric dilatation, bladder volume, bladder wall thickness, post-void residue, at least 5-6 times you mention, so that by default, those are mentioned.
Okay. So one more question which has come up is that urine routine is showing dipstick positive hematuria, like the occult blood is positive. So what should be the interpretation?
See, you have to follow it up with urine microscopy to see if there are RBCs or not. Because blood positive chemically can be due to a number of things. It may be due to actual hematuria. It can be due to hemoglobinuria, myoglobinuria. It can also be due to the presence of any reducing agent, because that is a very sensitive test which is present in the dipstick. So that reagent even reacts with some reducing substances in the urine and will give you positivity. So it should always be followed by microscopic examination to look for RBCs in a reasonably fresh sample.
So still we are on the topic of urine examination. So there are few questions on that. So if a child has asymptomatic child with pyuria, so how do we follow up with this child? Is there any long-term follow-up required?
See, we need to see why the pyuria is there. Pyuria can come from, besides urinary tract infection, which may be upper urinary tract. It can be from lower urinary tract. So all that. So one is infection. It can also be from local perineal infection, that some pus cells have come into the urine, including things like threadworm infestations. You can get pyuria. And you may also get by other irritants of the pathway, like a glomerular disease can give you some WBCs. Crystals in the urine, urate crystals, calcium crystals, they can all give you some WBCs, and hypercalciuria can give you, stones can give you. So there are multiple causes for pyuria, and sometimes just high fever can give you a few percents. So just getting pyuria, we don't know. We have to look at how significant it is, how repeatedly we are getting, and by history see whether it fits into any of, and not to forget medications. Many medications which we give may cause mild interstitial kidney issues, and that may present with pyuria.
Okay. So for proteinuria evaluation, is spot UPCR better or 24-hour urine protein is better?
See, in the pediatric age group, a urine protein creatinine is better because of errors in collecting a 24 hours urine sample. So that is a preferred modality. So for all practical bedside issues, that is sufficient. One caveat though, if you're dealing with an undernourished child or a malnourished child, then they may have much lower urinary creatinine than your normal child, and your ratios may be falsely high. So in those kind of children, it may not be very representative, but in all others, it would be preferred.
Okay. Especially in the peripheral places, most children, they have with fever, they have already received antibiotic. By the time you suspect UTI and then you send a urine culture, the urine culture is positive, but there is no pyuria. So should this be labeled as UTI because he has received antibiotic, but still his culture is positive, but there is no pyuria?
These are very difficult to answer. Means we have no answer because we don't know. Because to antibiotics, unless you have, nowadays you see all these ESBL carbapenem resistance from community. Barring those, UTIs respond well to antibiotics. So even 1 or 2 doses will alter everything, including sometimes your culture also. So it would be very difficult to say whether this was UTI or not UTI if we get something negative or positive after we have treated.
Okay. So, can you, ma'am, comment on one particular symptom which is with which the children present with is increased urine frequency? The child is passing every 5 minutes, 10 minutes, and the urine routine is normal. USG, the sonologist has reported as thickened bladder, and invariably they diagnose thickened bladder as cystitis, and the diagnosis is given cystitis. And also a comment on this neurogenic bladder and the patients who present with this increased urine frequency.
Yeah. So I think 3 things you've asked. One, with the increased frequency which is there, it's not an uncommon presentation. You find many children at some time or the other presenting with extraordinary frequency of micturition. Every 5 minutes they're passing. And most of the time it's very small quantities, few drops or few mLs of urine, but they have to go. And this starts suddenly, and usually no cause is found. They don't have a UTI. If you investigate, everything else comes normal, and the symptoms persist. So nobody really knows why they have this problem. What is the underlying cause? Is it an irritability of the bladder? Is it something psychological which is provoking it? But most of the time, it also settles on its own after a variable period of time. So you can just reassure the parents if your urine is showing nothing, your ultrasound is okay, creatinine is okay, that there's no abnormality. And the classical feature is that at night they don't have it. So it's obviously something in the awake state which their mind is responding to. And it's not happening at night. So that is a reassuring fact that this is not something organic to worry about, but there is really no known approved treatment for it.
Okay. And these USGs, which are
Radiological description, this is very, very common, but you cannot radiologically diagnose cystitis. Cystitis is a clinical diagnosis based on the symptoms the patient is having of dysuria, burning frequency, and the finding of urine pus cells and culture positive. So that is how you say that there is a cystitis. There's no high fever, nothing to suggest upper tract involvement. And so these may be accompanied by the sonologist finding that you may have like a thickened bladder wall because of the inflammation and internal echoes. But those does not, but if you don't have these symptoms, you don't have a urinary findings and you only have that sonography findings, you can't label it as cystitis.
Okay. So a comment on, ma'am, non-neurogenic, neurogenic bladders.
They are kind of difficult entities, one to diagnose, because you're obviously looking at a child who has a voiding problem. Okay, the voiding problem may be in the form of retention with post-void residue, or it may be dribbling, daytime wetting. So it can have a wide spectrum from a lot of incontinence to retention to in between. And so stepwise, always you have to rule out anatomic causes because those may be correctable by surgery. So these may be late presentations of PU valves, ectopic ureters, etc. And you have to exclude neurogenic bladders. Neurogenic bladders of overt ones are your meningomyelocele, spinal dysraphism, sacral agenesis. So good examination of the undressed child's spine, gluteal region. All that is needed. And sometimes you may have an occult spinal dysraphism like tethered cord. So sometimes you may even have to do an MRI to exclude. It's only when you 100% excluded anatomical and neurological causes, we've not found any. Since we don't know, we put it as non-neurogenic bladder, which is behaving like a neurogenic bladder. So that means we don't know why it's caused, but we know there's a problem. So it's by exclusion. So depending on the symptomatology, depending on what you find on ultrasound, MCU, uroflowmetry, sometimes maybe even urodynamics in some cases, you may have to tailor your treatment according to it.
And ma'am, any comment or a comment on incidentally diagnosed single kidney on USG and horseshoe-shaped kidney? So how will you follow up with these cases?
See, single kidneys are not uncommon. There are many times in adult life, it is discovered incidentally in a healthy 30-year-old or 40-year-old adult male or female, because ultrasound is done for something and you find they have just one kidney. You investigate and everything else is normal. They don't have any other issues. They live normal life, normal lifespan. But at the same time, if you detect single kidney, it's important to make sure that it doesn't have give protection because it only take lesser salt intake, avoiding NSAIDs and nephrotoxic drugs, and maybe have an annual checkup, look urine for protein creatinine ratio, blood pressure, and an annual check while they are growing to make sure that their kids are and not developing any new problems. Okay. Horseshoe kidney are different. There is an abnormality in the kidney development. They are fused together. So you have to see whether they are associated with some syndrome like Turner's or they are just an isolated finding. They're a little bit more prone to injury. They're also prone to little other complications like hematuria, stone formation, etc. So, but when you're counseling the patient, it is like they have to just be careful, look out for things if anything happens to come and show, and just monitor. It doesn't happen in every horseshoe kidney, but some of them will have some complications.
And your voice is cracking a little bit, maybe some network issue, but we will take the next
Uh,
question.
Pawan, can I ask one question?
Yes, sir. Yes, sir. Please.
Madam, if the child has undergone a renal transplant and he
Hmm.
is doing very well for 1 or 2 years, gaining weight, everything is going smoothly, and all of sudden you see that the creatinine has started again rising. So how to approach such cases?
See, a post-transplant care is hardcore nephrology because even though initially creatinine may be normal, it can rise due to a number of different reasons, right from rejection, other rare viral infections, drug toxicity. The drugs we give to prevent rejection themselves are nephrotoxic. So there are multiple causes, and sometimes there are late development of surgical issues like anastomotic renal artery stenosis. Various things may happen. So there are at least commonly half a dozen things which you have to rule out to arrive at a diagnosis, and many times they need a renal biopsy to assess what is happening internally.
Because sometimes they do come to the general pediatrician, they ask you what are the chances of rejection or what should we do now.
No, any rise in creatinine, even if it's a small rise like of 0.3 or 0.5 milligrams, would require a nephrology review. It's not to be ignored that if it goes up more, we'll see. One common thing is hydration. If they're taking less water, then you will have a little rise. So you should tell them to take plenty of water and show a nephrologist.
And what are the chances of this graft rejection, or if it is there, so can we prevent it further damage?
See, that's again the nephrology area, because they have to first decide by biopsies there a rejection, and then what type of rejection. There are different types of rejection, and each one has a different kind of treatment. So for most rejections anyway, there'll be increase in immunosuppressive therapy. So newer immunosuppressive therapies are intravenously may be given, stepped up, etc.
Role of any IVIG in this?
It depends on the type of rejection you're seeing and what. Some of them have a role in some rejections.
Thank you, madam.
Okay. So, ma'am, there is one question which is like a very common scenario in practice. Is ma'am, are you there, ma'am? Hello.
Yeah, I'm there. Yeah.
Yeah. So, NSAIDs are a common cause of acute kidney injury, as well as it can cause hematuria as well. So if ibuprofen or mefenamic acid has to be used, so what precautions does one has to take to prevent hematuria as well as to prevent the acute kidney injury?
See, first I feel the frequency of using them should go low. I would not say as never, but definitely not as commonly as we're doing. It cannot be first line, second line treatment for fever, because no fever is known to kill a child. The only people with high fever who are at risks are the febrile seizure children, who are a little different issue. And if you have hyperpyrexia over 104, those are the ones which can kill and cause damage. Your normal fever does not kill the child. It is your body's response, and a beneficial response to fight the infection should not be totally suppressed. Paracetamol acts well. You give 15 mg per kg, takes longer. Explain to the parent that you're doing it because you don't want to give strong medications. They are happy that you're a good doctor. You're not exposing the child to strong medications. They'll teach them sponging. So if in your judgment that this fever is not going to kill the child just because of temperature, avoid. Because that febrile state is a risk factor for getting NSAID toxicity, because the child is taking very little orally, is going to be underhydrated, he's not on IV, he's at home. The mother is struggling to give some liquids, and you go and add an NSAID to it. So if he is going to get a problem, he'll get it. So avoidance is the best, because it's not that Indian children are different from children in US and UK. They just get paracetamol for fever. And if they don't die of fever, why should our children die of fever? They die of the cause of the fever. So I'm a strong advocate of reducing the use of NSAIDs because you cannot totally abolish the side effects unless you totally hydrate the child, make sure you're giving no other simultaneous or sequential nephrotoxic drugs. It's not even simultaneous. You give ibuprofen today, you give amikacin tomorrow, sequential nephrotoxicity can occur. So you have to be the step back from NSAID use rampantly.
So there is one question that this child, if the child has dysuria, but no fever, no pyuria, but the culture is positive. But the child has dysuria, which is significant.
So it's possible if it's a properly collected sample and you're sure that they've collected well on time. Often there is contamination in this situation. So sure, then yes, there could be a lower urinary tract infection, which is causing the UTI cystitis and giving you this picture.
Okay. So there is one question on recurrent hematuria in school-going girl. So what should be the recurrent hematuria in school-going girl? So
See,
how to deal with this?
hematuria is almost about 100 causes if you see the textbook. So you have to rule out all the common ones, see if there's also proteinuria present. Are we getting hematuria because of some glomerular disease which is appearing periodic? In between, is the urine totally normal? Have we evaluated for all the common causes which are there? If yes to all that, then I think they would need to be looked at by pediatric nephrologists to see whether additional invasive investigations are needed.
And how do you evaluate any unexplained AKI where you cannot find any cause?
Many times unexplained AKI, if you're truly unexplained, means you're saying there was no preceding fever, no illness, nothing, then often there is some medication, which may be allopathy medication or they've taken some herbal medication, some non-allopathic medication, which they don't even think is harmful. They think all that is very good for health and doesn't harm anything. So most of the times when we've seen this kind of setup, where we just have no clue in the history and they've come with shutdown, it's turned out to be some toxicity due to drugs.
Ma'am, how much importance should be given to the report of debris in bladder on USG?
Yeah, this is the same thing when they say internal echoes or debris. Any moving particle will look like a debris or internal echoes. So it may be many things. It could be RBCs, it could be WBCs, it can be, just some inorganic substances which are present like urates, phosphates, etc. can also move. So it just means there's some particulate matter in the urine.
Okay, so I think most of the questions are taken care of, madam. And it was really an interesting session. Sorry, one more question we've got. So what is the significance of Gower sign in CKD? What could be the cause? There is one question.
See, we don't see it commonly, but in CKDs which are diagnosed very late, very long-standing, not been diagnosed, missed, nothing has been corrected, it's due to the secondary hyperparathyroidism, which causes a proximal muscle weakness. So you find that the combination of hypocalcemia, secondary hyperparathyroidism gives rise to that. Once you correct all that, you find that the ability to get up and climb and all that becomes nothing.
And one question on this polyuria, polydipsia, and nocturia. So how common is that? And in that, how much is the prevalence of renal tubular acidosis? How common is RTA?
See, if you get a definite history of polyuria and you're getting nocturnal urine, passing urine, drinking plenty of water, it is a tubular problem. So RTA would be an important one, and another one would be a CKD. That there is a chronic kidney disease, and already there is what do you call it? Tubular defect, concentrating defect is impaired. So the child is passing a lot of urine. So even in CKD, the polyuria is because the tubules are damaged. So it's a classical finding in any tubular disorder.
So there's one question was someone has asked, a 3-year-old nephrotic which was inappropriately treated with long-term steroids has recurrent UTI, and the culture is showing pan-resistant Klebsiella and is not going in remission, presently in partial remission. So how to deal with this situation? Pan-resistant Klebsiella in urine in nephrotic syndrome.
I think first thing is it a UTI or is it an asymptomatic bacteriuria? Because many times UTI is diagnosed just because we've done a culture. If the child has no symptoms of UTI, I would not label this as UTI. I would say nephrotic syndrome with asymptomatic bacteria, and perhaps that doesn't need to be addressed. If it is true UTI, then it has to be addressed like any other UTI. If you're fever and pyuria and you're growing in a properly collected sample pan-resistant thing, then basically in pan-resistant, you don't have anything which you can treat. But you can try, if it's a true UTI, you can try your usual medications which you give for UTI orally, because many times they are excreted in the urine in a higher quantity than they are in the blood. And they might still act when it looks pan-resistant. I would be very wary about treating such a child with antibiotics, will just increase resistance. I would concentrate more on, is it true UTI or just a bacteriuria?
Okay. So I think most of the questions are taken care of. There's one who is recently paropenem is quite a bit used for this UTI recently on OPD basis. So any comments on paropenem?
I can't come in because I've never used it.
Okay.
So I don't know anything about the drug and whether it's effective or no for UTIs.
Okay, so the bottom line is that definitely not to be used or to be used.
No, I would say you should not use. I have a great question mark about all the diagnosis of UTI. Because from sensitizing pediatricians to recognize UTI and don't miss the diagnosis and investigate, I've moved to the other end that probably you're wrongly diagnosing many UTIs. For each rightly diagnosed UTI, there are at least 5 which are labeled as UTIs, which are non-UTIs.
Okay. So I think so we should very happy that we had such a enlightening and enriching session, and we will conclude this session today, and I will hand over to Dr. Amal Pawar sir to give vote of thanks. Yes, thank you, madam.
Yes.
Thank you.
Yes, thank you. Thank you, Dr. Pawan, for introducing ma'am and also moderating these sessions and also taking up this large set of questions and answer session also. So friends, legends are the embodiment of courage, inspiring others to conquer their fears. So after hearing today's deliberation from ma'am, this line stands true. Ma'am, you have taken a lot of efforts to teach again these basic pointers needed to recognize the nephrology cases in early phase, and this will be very useful to all of us in our office practice. So thank you, Dr. Uma Ali ma'am, and all the delegates, PG students who have attended this session completely, and till now we have almost 250 delegates here. So thank you, Dr. Amgopal sir. Thank you, Dr. Bhavesh Mithia sir, for introducing ma'am to us. For today, we have heard her in many national, zonal, national, state level conferences and also national conferences. So thank you, Dr. Uma Ali ma'am, for your efforts and pain you have taken to prepare this all the academic material for us. So thank you once again from whole team Maharashtra. Thank you, ma'am. Thank you.
Thank you, the full team. I think I'm very impressed with your choice of various things which you all have done on Zoom. I think it has been very innovative and very different. Each one webinar is very different from the previous one I've had. And very informative.
Thank you, madam. I think today also we had more than 400 viewers live on Zoom link and more than 50-60 on YouTube.
Almost 500, almost total more than 4,000.
So
it
is a mini Mahapedicon.
Yes.
Yeah.
So friends, next week we will meet for the tips in office pediatric practice.
And yes, I will tell. The experts in next session, we have Dr. Anu Parma, who will be talking on movement disorders in children. And the second expert, the legend again, the president, Dr. Nitin Shah, will be taking on the childhood anemia. So
it will be slightly different topic. It will be use of iron other than iron deficiency anemia.
Anemia, yes. Okay, thank you.